Welcome back to NGN Deep Dive. Today, obstetric emergencies, preeclampsia and magnesium sulfate, postpartum hemorrhage, and the abruption versus Previa distinction. Remember, in OB you're always caring for two patients at once. Roadmap: preeclampsia and eclampsia, magnesium sulfate and its toxicity, postpartum hemorrhage with fundus first management, abruption versus Previa, a head-to-head, and practice from days 3, 12, and 24. Chapter 1. Preeclampsia. New onset hypertension after 20 weeks of pregnancy, with evidence the mother's organs are being affected. Preeclampsia with severe features is what you must catch. Expected: a blood pressure between 140/90 and 160/110, mild edema, some protein in the urine. Severe features that demand action: a pressure at or above 160/110, a severe headache or visual changes, right upper quadrant or epigastric pain, brisk reflexes with clonus and HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. That epigastric pain and those visual changes warn a seizure may be coming. Priorities: magnesium sulfate to prevent or stop seizures, antihypertensives like labetalol or hydralazine for severely high pressures, seizure precautions and a quiet, low-stimulation room, continuous fetal monitoring. And remember, the only definitive cure for preeclampsia is delivery of the baby and placenta. Magnesium sulfate is a high-alert drug, so know its safety numbers. The therapeutic range is 4 to 7. The first sign of toxicity is loss of the deep tendon reflexes, so you check reflexes routinely. Then, respirations under 12 a minute, and a urine output under 30 mL an hour, because magnesium is cleared by the kidneys. The antidote is calcium gluconate, and it stays at the bedside whenever mag is running. If-then rules for magnesium: if the deep tendon reflexes disappear, suspect toxicity, stop the infusion and notify the provider. If respirations drop below 12, stop the mag and prepare calcium gluconate. If urine output falls under 30 mL an hour, magnesium can build up, so reassess and consider holding. And for clear toxicity, give the antidote, calcium gluconate. Chapter 2. Postpartum hemorrhage. The leading cause is uterine atony, a boggy uterus that won't contract to clamp off the vessels where the placenta was attached. Management is fundus first. Assess the fundus. Is it firm or boggy? If it's boggy, massage it first, because atony is the top cause and massage often works immediately. Empty the bladder, since a full bladder pushes the uterus up and prevents it from contracting. Give uterotonics. Oxytocin first, then methyl-ergonovine or carboprost. And estimate the blood loss. Get large bore access and prepare blood. Traps to know: methyl-ergonovine is contraindicated in hypertension and preeclampsia because it raises blood pressure. Carboprost can trigger bronchospasm, so use it cautiously in asthma. Don't skip the bladder. A full one is a classic reversible cause, and if the fundus is firm but bleeding continues, stop massaging and think trauma, like a laceration. Chapter 3. Placental abruption versus placenta previa. One word: painful or painless, separates them, and it changes what you're allowed to do. Here's the whole distinction. Abruption is the placenta detaching too early. The bleeding is painful and dark, and can even be concealed, with a rigid, board-like, tender uterus. Previa is the placenta covering the cervix. The bleeding is painless and bright red, with a soft, non-tender uterus. The rule that saves lives: never perform a vaginal exam when previa is suspected, because it can trigger catastrophic hemorrhage. Painful and rigid means abruption. Painless and bright red means previa. They share emergency priorities: continuous fetal and maternal monitoring, large bore, IV access with fluids and a type and cross-match, and a left lateral position to improve placental perfusion. No vaginal exam if previa is even suspected. And be ready for an emergency cesarean. 2 patients, 1 resuscitation. Practice from day 3. A client on magnesium sulfate for severe preeclampsia has absent reflexes, a respiratory rate of 10, and a urine output of 20 mL an hour. What's the priority? Pause and choose. The answer is B. Stop the magnesium and prepare calcium gluconate. Absent reflexes, respirations of 10, and low urine output are textbook magnesium toxicity, and every finding points to dangerous accumulation. The dangerous trap is D. Continuing to document while the drug keeps infusing. Lost reflexes are the earliest toxicity sign, and they demand stopping the drug right now. Second question, from day 24. A client at 34 weeks with bright red, painless vaginal bleeding and a soft, non-tender uterus. Which action is contraindicated? Pause and decide. The answer is C. The digital vaginal exam is contraindicated. Painless, bright red bleeding with a soft uterus points to placenta previa, and a vaginal exam can perforate the placenta and cause massive hemorrhage. The other three, monitoring, IV access, and left lateral positioning, are all appropriate. The whole question hinges on recognizing Previa from that one word, painless, and knowing the single forbidden action. Synthesize it. Center. Magnesium toxicity. Actions: stop the infusion, give calcium gluconate, and support breathing while notifying the provider. Monitor the respiratory rate and effort, the deep tendon reflexes, and the magnesium level and urine output. That's how you catch and reverse mag toxicity. That's the OB emergencies: preeclampsia and magnesium, postpartum hemorrhage, and abruption versus Previa. Daily NGN questions at 5, every guide free at ClinicalJudge.com. Subscribe, comment your score, save the series. You learned it. Now go apply it.